Hello everyone, I am Dr. Vaibhav Roh, Senior Consultant, Internal Medicine, Department of Internal Medicine, Max Saket, New Delhi. Today we are going to discuss a case of a 58-year-old gentleman named here as Mr. AB. So Mr. AB came with a history of type 2 diabetes mellitus since past 4 years. Also, he was having obesity, hypertension, dyslipidemia, and obstructive sleep apnea. On his physical examination, his general condition was stable. BMI was found to be 32 kg per meter square. BP was 130/82, and heart rate was 60 beats per minute. His lab investigations showed HbA1c of 8.3%, eGFR of 70 ml per minute, LDL of 69, HDL of 35 mg, triglycerides were 250, AST and ALT levels were 70 and 100 respectively. He was taking medications metformin 1000 mg twice a day for diabetes. For blood pressure, he was taking lisinopril 40 mg once a day, metoprolol 100 mg once a day, atorvastatin 40 mg once a day for cholesterol, and aspirin 75 mg once a day. So patient profile here, we have a short duration of type 2 diabetes, and this patient is relatively young. Also, he has no major comorbidities with no major complications that would reduce his lifespan. He is also at low risk of hypoglycemia. So he would benefit from a more stringent goal for sugar control. However, he is also obese, hypertensive, dyslipidemic, and with obstructive sleep apnea disorder. So the American Diabetes Association recommendation for stringent sugar control is having HbA1c of less than 7%, which is a reasonable goal for most non-pregnant adults. In addition to efficacy of treatment, following considerations predominate in determining pharmacotherapy for him, such as risk of hypoglycemia, weight loss, minimizing weight gain, complications like heart failure, atherosclerotic cardiovascular disease, chronic kidney disease, and finally, cost of treatment. So here, Mr. AB is willing to start another medication, but is concerned because he sometimes forgets to take his pills and fears that additional pills will make it only worse. Also, he does not want to have injectable insulin therapy. Therefore, we can opt for a fixed dose combination for him, which will improve patient adherence by once daily dosing, less complex treatment regimens, having fewer pills, and improve side effect profile and adherence. People with type 2 diabetes mellitus commonly live with multiple comorbidities, among which hypertension and cardiovascular diseases are the most common. Monotherapy cannot address these multiple issues and often leads to failure to maintain glycemic control over time. Current diabetes guidelines encourage early adoption of oral combination therapies while simultaneously emphasizing the importance of individualized treatment. According to the American Diabetes Association recommendation, in appropriate high-risk individuals with established type 2 diabetes, the decision to treat with GLP-1 receptor agonist or SGLT2 inhibitor is to reduce cardiovascular risk factors, heart failure, cardiovascular death, or chronic kidney disease, which should be considered independently of baseline HbA1c or individualized HbA1c target. Empagliflozin drug combination along with linagliptin is available as first-in-class treatment in SGLT2 inhibitor and DPP4 inhibitor combination. SGLT2 inhibitor is a class of novel oral glucose-lowering agent that mediates glucose-lowering action by increasing urinary glucose excretion via inhibition of the sodium glucose cotransporter 2 in the proximal tubules of the kidneys. The salutary effect is its ability to act independent of insulin secretion and action and render it suitable to administer at any stage of disease course. DPP4 inhibitors exhibit its glucose-lowering effect by the elevation of incretin hormones and subsequent augmentation of glucose-dependent insulin secretion and inhibition of glucagon release. Combination of these agents has potential to show the additive glycemic control due to their complementary effects. Empagliflozin cardiovascular outcome event trial in type 2 diabetes mellitus was a study which reported lesser cardiac risk factors outcome in a significantly lower percentage of population. People, that is, who were taking empagliflozin for type 2 diabetes had lesser cardiovascular complications as compared to the placebo group. In addition, cardiovascular safety of linagliptin, which is a DPP4 inhibitor, was further elucidated in the Carmelina and Carolina trials. HbA1c decrements by empagliflozin-linagliptin combination has demonstrated up to 1.81% reduction in the HbA1c from an HbA1c baseline of 8.5% or more at 24 weeks use in metformin treated groups. The benefits on glycemic control were maintained at 52 weeks in metformin treated groups and at a higher percentage of patients having HbA1c less than 7%, which was reported following this combination use. This combination also offers a suitable component in strategy to achieve target HbA1c without increasing risk of hypoglycemia and weight gain, and with overall improvement in the lipid profile. A reduction in the incidence of genital infections associated with SGLT2 inhibitors has been reported when a DPP4 inhibitor is added, perhaps because of better glucose control, although other possible mechanisms remain to be investigated. In summary, the combination of empagliflozin with linagliptin provides a robust HbA1c reduction and 2 to 4 times higher odds of patients reaching the goal HbA1c compared to individual agents with low hypoglycemic risk. I hope this session was informative to you all. Thank you very much.